So surgery is a massively common process in the UK, with 7.9 million surgical procedures carried out every single year. These procedures are often greatly demanding on the body. The resulting inflammatory response hugely increases the patient's tissue oxygen demand, and therefore they must have a sufficient functional capacity to be able to increase their cardiac output and meet this demand. Diminished functional capacity is a well-established predictor of poor surgical outcome in the literature. However, some patients are more likely to have this limited functional capacity than others, with high-risk patients particularly at risk of this. High-risk patients are defined as any patient with a greater than 5% risk of mortality during or following surgery. While this population makes up just 1 in 8 of the patients we encounter, they account for over 80% of perioperative deaths. This is massively disproportionate to their lower risk counterparts, and there are several patient factors which are commonly present in the high-risk population, which may be explanatory for this. Things like preoperative inflammation, frailty, and sarcopenia have all been identified as independent predictors of poor outcome in the surgical population, and these are very common in the high-risk population. Therefore, the aims of this project were to identify the association, if any, between functional capacity, preoperative inflammation, frailty, and sarcopenia with surgical progression and outcomes following patient review at the high-risk anaesthetic clinic. This was a retrospective observational study of 533 patients reviewed at the high-risk anaesthetic clinic based in the Glasgow Royal Infirmary. 6-month, 1 year, and extended survival analysis were all carried out. However, this only shows the 1-year survival results. The forest plot shows the Cox proportional hazard model of best fit for 1-year survival in our population, and the corresponding Kaplan-Meier looks at the effect of frailty on 1-year survival. It shows that while frailty is significantly associated with poorer outcome at 1 year in univariate assessment, this significance was lost when adjusted for covariates. Interestingly, an ROC-derived cutoff for the neutrophil lymphocyte ratio of 4.6 was found to be significantly associated with survival, with a lower neutrophil lymphocyte ratio being associated with better survival. Similarly, a higher functional capacity with a higher DASI-MET score was significantly associated with better survival in our population. These trends were continued at 1 year and extended survival, and therefore, in conclusion, we found that assessment of the preoperative inflammatory burden and functional capacity is very likely useful in evaluation of the high-risk surgical patient. An increased functional capacity by DASI score showed that there was very likely increased 1 year and extended survival in our population, and a decreased inflammatory burden by neutrophil lymphocyte ratio was associated with increased survival at every time point analysed. Therefore, these parameters are very likely to be effective screening tools for surgical progression in the high-risk population, and may also allow for optimizable targets in our population, allowing us to reduce mortality where possible. Thank you so much for listening.